I would like to invite Dr. Ria Pimentel to talk to us about how she's going to monitor all of us.
Thank you, Dr. Reddy, and thank you, Dr. Waldo, for that interesting talk. It's always fun to look back and see how far we've come, and also I think your talk also sort of highlighted the importance of mentors. So thank you very much for that. Good afternoon, or good morning, actually, everybody. I'm here today to talk about the state-of-the-art and heart rhythm monitoring, and this is kind of a topic that when I started presenting it, I started looking at it, I wasn't quite sure exactly what I was going to do. So what I've ended up doing is kind of spending the first part of this kind of reviewing the different types of monitoring that are present, and then also kind of trying to apply this to a real-world application. So here are what I would generally consider the indications for cardiac monitoring. And I think there are three big ones here. The evaluation of syncope, both looking for brady or tachyarrhythmias that could cause a syncopal event. Atrial fibrillation, both in the diagnosis of it as well as determining rate control, frequency, and duration of the AFib. And then as surveillance after atrial fibrillation procedures, particularly AFib ablations, but also after initiation of antiarrhythmic medications. The third indication that I think is probably somewhat newer but very interesting is the idea of assessing these patients with cryptogenic stroke for asymptomatic atrial arrhythmias. And keep in mind when I'm talking about indications for cardiac monitoring, I'm referring to outpatient ambulatory cardiac monitoring. So when I look at patients and I try and figure out what's the best ambulatory monitor for them, I ask myself these questions. How often do the symptoms occur? Is the patient symptomatic with arrhythmias? Does the total arrhythmia burden matter to me? And lastly, how will this affect my practice from a manpower and reimbursement standpoint? And I think that's sort of something we don't think of immediately, although there is definitely, with these different types of monitors, a certain level of staff issues that are required in order to get good information in a timely fashion. So these are the type of monitors available to us today. Continuous telemetry monitors, external event-activated recorders, mobile cardiac monitors, and implantable loop recorders. And we'll go through all of these very quickly. I think it is safe to say that as our cardiac monitoring has evolved over the years, the yield on symptomatic arrhythmias has especially increased. And you'll see way at the bottom, Holter monitors, which are sort of our tried and true and initial method of monitoring, really only will give us a yield about 5 to 13%, all the way up to the mobile cardiac telemetry monitors and the implantable loop recorders, depending on whether we're looking for symptomatic or asymptomatic arrhythmias. So to start off, the Holter monitors, you probably already know, Norman Jeff Holter invented this back in 1947. The original Holter monitors weighed between 80 and 85 pounds, and they were placed on your back as a backpack procedure. The Holter monitors at that point were revolutionary because they allowed patients to go about, as Dr. Holter said, their regular business, although you can see that it would probably be very difficult to go about your regular business with that pack on your back. Nevertheless, Holter monitors have been very important for us when we see patients that experience daily symptoms in terms of quantifying the arrhythmia as well as diagnosing it. The drawbacks to it, of course, are their short duration of data, somewhere between 24 and 48 hours, and of course the patient has to experience that arrhythmia during that time. Finally, there's no real-time physician notification, so oftentimes we have patients, we get Holter monitors back, they might have had a 10-second pause, but we find out, a few days later. So overall, as I mentioned before, the diagnostic yield is about 5 to 13%. Holter monitors are well accepted in the medical community as well as with insurance companies, but again, very difficult to wear. We all know about the patch allergies and the electrode problems that patients have, so compliance can be an issue. But overall, it's a low-cost, high-yield therapy in patients who have frequent symptoms. I wanted to bring up some of the newer technology. This is, I think, it's referred to as a ZEO system. It's a patch that you can put in the left deltopectoral area. It's sort of like a jelly-like consistency, and it's FDA approved for up to 14 days of continuous monitoring. So like a very long-term Holter monitor. There is a mechanism for which patients can mark these symptoms during the time, and the patients can actually do what they want take showers, whatnot with it. They just can't submerge it in water, so you can't be in a pool or anything like that because the gel will fall off. There's, again, no access to rhythm strips during the monitoring system. During the monitoring time, excuse me. So at the end of the 14 days or however days you prescribe it, you would send it back through the mail and you would get a report as to what happened during those 14 days. So this is just one study looking at the comparatives between a Holter monitor and the Zio system, and basically what it says is that with paroxysmal, persistent arrhythmias, the diagnostic yield is much higher with 14 days versus 48 hours. So here we see that the Holter monitor, when we were trying to look at cost and value perspective, the Holter monitor ends up being a very low cost but limited yield product. You know, the Zio system kind of increases our yield with a lower cost, but now we're going to talk about some of the other types of event recordings that we can do. And primarily the external event recorders are something that we utilize a lot. These are for patients with infrequent symptoms. And in some cases, we'll use the devices that don't require the electrodes. The external recorders, if they're auto-trigger, unfortunately will be based on an algorithm that can be difficult at times. There's a lot of false positives for it. And there is a memory capacity for these devices, which requires the patients to actually download the device. The post-event recorders, which you've probably all seen, are the AKA heart card recorders, are the ones where the patients carry them in their pockets or wherever, and when they have an event, they place it on the chest wall to initiate, to mark an event. Again, the patient has to have the recorder on them in order to initiate it. So if you have a patient that it's not good about bringing it with them at all times, that's a problem, and it's best used in patients who have prolonged symptoms. The looping monitor, which is something that we're all familiar with, again, is the same sort of concept, except it utilizes wires and patches the same way a Holter monitor does. So although you can capture the initiation of the event more easily with a loop recorder, you have difficulties, again, with patient noncompliance. And remember, that whole act of transmitting data once they record it, which is not always done right at the time of the event, is actually quite complex. And they liken it to the ability to use an ATM machine. So in patients that perhaps are not with it enough to use an ATM machine, this might be a difficult thing for them to also pursue a looping and event monitor. There was one study I will mention way back in 1998 looking at looping event monitors and the as it pertains to diagnosing palpitations. And what they found actually in this particular study is that the optimal duration of monitoring necessary to diagnose palpitations was only 2 weeks, which kind of, and as we go forward, we'll talk about some of the other studies that have shown different results. Again, the auto-trigger loop recorder is just a looping event monitor with an additional algorithm to detect certain arrhythmias based primarily on rate without a patient trigger, and this is mostly useful to detect asymptomatic arrhythmias. Again, there have been studies looking at the auto-trigger loop recorders versus both plain old loop recorders and Holter monitors, and we find that obviously there's an increase in detection of both symptomatic and asymptomatic arrhythmias with these auto-trigger devices. I just wanted to say a word about these, what we call patient-initiated EKG monitors or ECG monitors. This is something called the Arica Health 100. I don't know if you guys have ever seen this, but it's a puck-sized device that patients carry around in their pocket. And when they have an arrhythmia, the two dots on either side there, they put their thumbs on it, and it will record a single-channel ECG. This can be downloaded onto their Android, iPhone, or PC, and then sent via cloud platform to you, the medical provider. So in this way, all of your patients, anytime they have a symptom or a feeling or sensation, could actually give you a single lead EKG. The current insurance reimbursement uses the mobile cardiac telemetry CPT codes, and at this point, the cloud platform is free. Again, there is another system out there called a LiveCore, which is another app for actually utilizing iPhones, and it's the same process. It is a back of an cover to an iPhone, where there are two areas to put your fingers, and it will record again another single-channel ECG that you can send over wirelessly over a cloud base to your provider for diagnosis and further recommendations. These particular devices are sold in the United States to licensed medical prescribers as a prescription to record, transmit, and store single-channel ECGs. Not currently covered by insurance carriers. I believe the cost is $200 for these patients to obtain them after they get a prescription from their medical providers, and currently is working with the iPhone, I believe 4 and 4S, but not 5 as of yet. So then we move on to cardiac telemetry monitors, mobile cardiac telemetry monitors, and these, again, are devices that automatically record rhythms based on preset parameters for acquisition. And the device is a couple wires, again, with sticky patches that either transmits automatically via the cellular system, or it transmits to a handheld device, which then goes via the cellular system to a monitoring station. Symptoms, again, can be easily tracked. And I think one of the big things about a mobile cardiac telemetry monitor is there's always somebody looking at the rhythm at the time that it's transmitted. So there is immediate feedback between the central monitoring station and the patient. There's also obviously an increased likelihood of detecting asymptomatic arrhythmias, but again, with the wires and the cellular phone systems that are utilized, sometimes compliance can be an issue, and it tends to be relatively expensive compared to other monitors. This is just a study looking at cardiac telemetry monitor comparative to loop recorders, and again, as you would expect, clinically significant arrhythmias, atrial fibrillation, both symptomatic and asymptomatic, are more commonly seen with these mobile cardiac telemetry monitors compared to loop recorders. Finally, I just want to talk about implantable loop recorders, and again, these are small jump drive size recorders that can be subcutaneously as an outpatient surgical procedure. The advantage of these devices, it has a 3-year battery longevity, and it can record predetermined abnormal rhythms, including bradyarrhythmias, pauses, and tachyarrhythmias. There is a patient-triggered option, and of course there is some remote follow-up in some of the types of devices. These are best used with patients with very infrequent symptoms and a suspected arrhythmia, or when the syncope that they have is incapacitating, meaning they can't actually trigger the device to let you know that they're having an event. It is an invasive procedure. A lot of times oversensing and undersensing can occur based on where you place the device subcutaneously, and the ability to transmit it remotely is limited. It's at this point still using a landline system. So again, going back to what I had talked about previously, how are we monitoring patients today from a cardiac standpoint? Again, I've already talked to you about different ways to diagnose infrequent or incapacitating syncope, and we're not going to touch on atrial fibrillation detection and monitoring, although I really struggled hard before I decided which of these two I was going to talk about, because I think that's another burgeoning aspect of remote monitoring, or monitoring in general, and cardiac monitoring following procedures and surgery, as we try to determine who it is that we can discontinue anticoagulation and who is at risk for stroke. What I decided to focus on for my last 7 minutes, it looks like, is the etiology of cryptogenic stroke, which again is a very hot topic. We've seen lots of papers come up in the last 3 or 4 years talking about how to diagnose, especially arrhythmias, in these patients with strokes of unknown causes. And these are the different etiologies of stroke, and it's just a review. The types of ischemic strokes that we see are atherothrombotic. About a quarter of patients may have stenotic arteries feeding an area of infarction. Known cardioembolic causes of stroke, meaning atrial arrhythmia due to thrombus formation or an arch thrombus. And then there are of course, uncommon vasculitis type pictures that can cause an ischemic stroke. All told, cryptogenic causes, or basically unknown causes, account for about 25 to 40% of all ischemic strokes. So why does this matter, and why is atrial fibrillation even involved? Well, we already know that AFib increases the risk of stroke by 5-fold, and about 90% of paroxysmal episodes can be asymptomatic. Unfortunately, the risk of stroke is the same whether you have paroxysmal or permanent AFib. I think that's generally agreed upon. And the detection of atrial fibrillation in these stroke patients will actually change their treatment. Now remember that in these patients, the only indication for anticoagulation is really atrial fibrillation. Otherwise, these patients would be treated with antiplatelet agents and things like that. In addition, we could obviously treat the atrial fibrillation earlier and prevent hopefully the natural progression of the disease. So when we start talking about monitoring and looking for AFib in these stroke patients, we see, probably not surprisingly, that the more you look, the more AFib you'll find. And these are just a few studies looking at different lengths of time of monitoring and the percentage of patients that have atrial fibrillation detected. And 1.2 years of continuous monitoring, 28% of patients with a history of stroke had atrial fibrillation detected. This is a TRENDS trial, which came out a few years ago, looking at the relationship of atrial arrhythmias and stroke risk. And basically what it was is an observational trial looking at patients who had more than one stroke risk factor, who had devices in place already, so pacemakers or defibrillators that could tell us whether they were having atrial arrhythmias. We all have that situation where we have device checks routinely and we see that patients have some atrial arrhythmia on their device check, and it's always a question of when is it that we need to worry about it. Well, what they found is they subdivided these patients into three burden levels: low ATAF burden, no burden, and low meaning less than 5.5 hours on any one day in a 30-day period, or high ATF burden, meaning more than 5.5 hours. And really what they found is that your low burden and your no burden people had a very low annualized thromboembolic rate. However, ATAF burden of greater than 5.5 hours doubles the thromboembolic rate. So this has kind of led to a lot of questions as to, okay, maybe we should not be ignoring what these devices are showing us when we see these asymptomatic atrial arrhythmias. It also calls into the question the old adage that 24 hours is necessary for clot formation and thrombus and subsequent stroke. Perhaps the better number is 5.5 or 6 hours. This is a subgroup analysis of the TRENDS trial, actually looking at patients who already have had a stroke and following them post-CVA through their device. And what they found is that of 28% of patients had newly detected atrial fibrillation lasting more than 5 minutes. And more importantly, it took them more than 30 days. The majority of them required more than 30 days to see this newly detected atrial fibrillation. So again, sort of kind of trying to tell us that maybe we need to monitor these patients longer in order to get a good handle of whether they're having atrial fibrillation or not. The ASSERT study is another study looking at ATAF and stroke, and again, these are patients that had devices placed who had high CHAD scores, and they were followed just for 2.5 years. And if in their first 3 months they had a subclinical episode of atrial fibrillation, what they did is they put those people in a different category and they followed everybody. And what they found was that there was an increased risk of clinical atrial fibrillation if you had the subclinical AF in the first 3 months, and also there was an increased risk of ischemic stroke. And so what they showed is that anything over 6 minutes, which is what they described as their cutoff for atrial fibrillation, was a harbinger of increased risks of stroke. But really, if you break down the numbers, because this study received a lot of press early on, or at least a lot of discussion early on about whether 6 minutes is a big deal, what they found is the annualized stroke risk was much higher after 17.5 hours. So that's good. These are a couple other studies looking at mobile cardiac telemetry with cryptogenic stroke. And in this particular study, they did 21 days of mobile cardiac telemetry monitoring, and they found after a median of 7 days, they were able to detect 23% of patients had atrial fibrillation. And they were all very short, kind of suggesting, and the suggestion is that the short episodes of AFib may be biomarkers for more prolonged and significant episodes. Another study looking again at mobile cardiac telemetry, basically showing that they were able to detect 27 or 17.3% of patients with undiagnosed atrial fibrillation and cryptogenic stroke. So this AFib detection strategy that we see depends on our monitoring strategy, and this is actually a study. This is actually looking at post-catheter ablation. But you can see the longer you assess these patients, the more likely it is that you will detect atrial fibrillation if it is present. This is a study looking at actually implantable loop recorders for diagnosing atrial fibrillation and embolic cryptogenic stroke. And in this case, again, about 25% of patients, AFib was detected, and the median time to detection was 4 months. Another study looked again, and they saw that the detection rate was 44.5 days. So I think what we keep seeing here is that the time to detection becomes longer and longer the more we look. The surprise study, which looked at 71 patients with cryptogenic stroke and no AFib on telemetry, again looked at this, and they found that it took about 105 days from CVA onset to the first event. So not a trivial small amount of time in order to appropriately diagnose and treat these patients. I want to just go back again very quickly that the implantable loop recorder, the indications for use, there are actually two, and the one that cryptogenic with stroke would fall under is patients with clinical syndromes or situations that increase risk of cardiac arrhythmias. But the second indication for loop recorder implantation is patients who experience transient symptoms, dizziness, palpitations, syncope, chest pain that could suggest a cardiac arrhythmia. This is an indication for an implantable loop recorder. And this is just a quick slide I threw up looking at the reimbursement coverage status for, in this case, reveals. And you can see that the diagnosing suspected AFib, which is cryptogenic stroke, across the board, Medicare and private payers will cover this without any issues. If you have a good relationship with your neurology colleagues, as we tend to do here at KU, we talk back and forth a lot about cryptogenic stroke and how to deal with these patients as an outpatient. One of the things that what I've noticed is that if the implantable loop recorder is placed during the hospital admission for cryptogenic stroke, say the patient has already had their 72-hour Holter monitor, their TE and whatnot, their vascular studies, the reimbursement is much higher as a surgical DRG, which it becomes than a medical DRG. And I was actually surprised at the payment difference, but it is certainly there. So I want to finish my last 3 slides with an implantable loop recorder study, and this just kind of highlights what I've been talking about. This is an 85-year-old female with recent ischemic stroke of unknown cause, no previous history of cardiac disease, normal LV ejection fraction, but she does have some risk factors for AFib. She's obviously has hyperlipidemia, and she's older, and she has hypertension, I believe. Her previous workup showed normal Holter, normal ECG, and she had a Reveal XT implanted. She saw her electrophysiologist 11 days after implant, no atrial fibrillation at all. Everything was going well. At 3 months, however, we noticed that she has had atrial fibrillation. And, oops, sorry, that was the wrong one to push. So you can see after the red arrow to the right there is the atrial fibrillation burden, hours per day, and the ventricular rate of AFib, in AFib underneath that. And on the right, I have that the percent of time in AFib was actually 19.2%. So this patient, can you go forward for me? This patient actually was initiated on anticoagulation, and the Reveal monitor continues to be in place for monitoring her atrial fibrillation burden. So in summary, outpatient cardiac monitoring has been increasing in scope and range since the advent of Holter monitors, and there are numerous options today available to the clinician for both diagnosing as well as monitoring these patients. There are newer outpatient monitoring options which will allow patients to take a more active role in their treatment, although this must be balanced with the increased medical and legal responsibilities for the physicians. And patients with cryptogenic stroke may benefit from long-term monitoring in order to optimize their medical therapy. Thank you.